Hello, everyone. Welcome to PodBites, where we break down complex medical topics into bite sized pieces perfect for your commute, coffee break, or whenever curiosity calls. Today, we're joined by a special guest, Shahd Al Heijani.
Hi everyone, it's great to be here. Let's jump right into today's discussion.
So, Shahd, today's topic is diuretics. I've heard they're used quite commonly in medicine, but let's start with the basics. What exactly are they?
Great question. Diuretics are drugs that promote urine production by increasing the excretion of water and sodium. They work on different parts of the nephron, the functional unit of the kidney, and they help reduce fluid overload.
So, they basically help the kidneys flush out extra fluid?
Exactly. That's why they're so useful in managing conditions like hypertension, heart failure, and edema.
Okay, so when would you typically prescribe diuretics? Are they just for conditions related to fluid overload?
Not all. They're also used for other conditions, like glaucoma, nephrolithiasis, which is kidney stones, and even some electrolyte imbalances.
Sounds pretty versatile. Alright, let's break down the different types of diuretics and how they work. Starting with the weakest diuretic, carbonic anhydrase inhibitors. What do we need to know about carbonic anhydrase inhibitors?
These drugs, like acetazolamide, act on the proximal tubule of the nephron, and as you can guess from the name, they block the enzyme carbonic anhydrase, which normally helps the cells of the proximal tubule absorb sodium and bicarbonate. So by blocking this enzyme, this drug reduces the reabsorption of bicarb and sodium. And of course, where sodium goes, water follows. So overall, it increases the excretion of bicarb, sodium, and water into the urine. But they're not that powerful as diuretics because most of the sodium that was excreted by this drug just gets reabsorbed at a later part of the nephron.
Oh, so by the end of the nephron, it would almost be like nothing happened in the first place.
Yep.
Got it. So acetazolamide inhibits sodium and bicarb retention, and we said they're not super powerful as diuretics, but I'm guessing they're more useful for other things?
Exactly. I didn't mention this earlier, but carbonic anhydrase works in places other than the kidneys. Carbonic anhydrase is essential for producing the aqueous humor of the eye, so inhibiting carbonic anhydrase would decrease aqueous humor production. So who do you think this would be helpful for?
Patients with glaucoma?
Yes, you got it. Besides glaucoma, it also helps with cases of alkalosis, and one example of that is altitude or mountain sickness. And that's because when you're at high altitudes, you start to breathe really fast. So if you're losing carbon dioxide, you get respiratory alkalosis. So with acetazolamide, you're excreting the bicarb, remember? And excreting bicarb makes the blood more acidic and counteracts the alkalosis you got.
Okay, so we use them for glaucoma and mountain sickness. But what's the catch? Are there any side effects?
Of course there are. The big ones are metabolic acidosis from the loss of bicarbonate, as we mentioned. And another one is paresthesia, that tingling sensation. Patients might even get tinnitus or loss of appetite.
Okay, so metabolic acidosis, tingling, tinnitus, and loss of appetite. Next up, osmotic diuretics. What do they do?
Osmotic diuretics, like mannitol, act on the descending limb. They work by increasing the osmotic pressure in the renal tubules. It's basically a sugar alcohol that gets filtered freely but can't get reabsorbed. So this high concentration pulls all the water out to the renal tubules, leading to increased urine production. It's actually the only diuretic that causes only water diuresis without the typical natriuresis.
Oh, okay, so they prevent water from being reabsorbed in the descending limb. But when would you need to use something like mannitol?
Osmotic diuretics are lifesavers in certain emergencies, like in reducing intracranial pressure in cerebral edema. You can imagine that because it's so concentrated, it draws the extra water out of the brain and into the blood, which reduces the pressure. In the same way, it also lowers intraocular pressure in glaucoma. It can even be used to prevent acute kidney failure. In acute kidney injury, the kidneys are not getting enough blood, so the renal tubules start to get damaged and obstructed, and urine flow decreases. Now mannitol comes in and pulls water into the tubules and flushes out the wastes, so it prevents waste accumulation when renal blood flow is compromised.
Wow, okay, so it reduces intracranial pressure and intraocular pressure, and it helps with acute kidney injury. But are there any downsides?
Unfortunately, yes. Side effects include pulmonary edema and fluid overload, especially in heart failure patients. It may also cause electrolyte imbalances like hyponatremia, first when it dilutes the sodium levels, but then it causes hypernatremia as it causes increased diuresis.
Wait, so how does it cause fluid overload and diuresis at the same time?
Well, like we said, initially mannitol drags all the water into the blood. That's how it helped with cerebral edema. But after that, it takes all the water to the kidney to act as a diuretic. Imagine what the initial increase in blood volume would do to a patient who already has volume overload.
That would not be good. They're definitely not for everyone then.
That's right. They're contraindicated in severe heart failure, pulmonary edema, and established renal failure.
Okay, now let's talk about loop diuretics. I think they're the main character when it comes to diuretics.
You're not wrong. They are the most effective and can be used in urgent situations. Loop diuretics, like furosemide, are the most potent diuretics. From the name, they act on the ascending loop of Henle. They actually bind to albumin in the plasma, and the kidney secretes them at the proximal tubule. And in the tubules, they inhibit the sodium-potassium 2-chloride cotransporter. And this inhibition leads to massive sodium and water excretion.
Got it. So we inhibit the sodium-potassium 2-chloride cotransporter and lose water and sodium. But I'm kind of confused. How does that happen exactly?
Okay, I'll break it down step by step, but I want you to focus really well. Loop diuretics, like furosemide, work by blocking the sodium-potassium 2-chloride cotransporter. Normally, this transporter helps reabsorb sodium, potassium, and chloride from the fluid in the lumen into the cells. Then, these ions get transported from the cells into the interstitium on the other side, and when there's a lot of potassium in the interstitium, it leaks back into the lumen once again, causing a lot of positive charge there. And this positive charge will push magnesium and calcium ions away from the lumen and to the interstitium.
So now we have chloride and sodium reabsorption, and on top of that we have calcium and magnesium reabsorption too.
Exactly. So by blocking the sodium-potassium 2-chloride cotransporter, you'll stop all this pathway, meaning that sodium and water stay in the tubule and are excreted in the urine. This also causes magnesium and calcium to be excreted as well, because the positive charge that helps them get reabsorbed is lost.
That was a lot. Now I understand why they're the main characters. So when do we use them?
Loop diuretics are great for pulmonary or peripheral edema, severe hypertension, acute renal failure, and they're used to treat certain electrolyte imbalances like hypercalcemia.
Okay, so what's the downside of being so potent?
Their side effects include, first, electrolyte imbalances like hypokalemia, hyponatremia, hypomagnesemia, and hypocalcemia. Second, ototoxicity, and that's because the sodium-potassium 2-chloride cotransporter is also important for making fluid in the ears called endolymph. Third, hyperglycemia and hyperuricemia, which can trigger gout, and finally, hypovolemia and low blood pressure.
So two hyperglycemia and hyperuricemia, and everything else is hypo.
Yes, pretty much.
What about the contraindications?
Loop diuretics are contraindicated in patients with sulfa allergies, except for ithacrinic acid, and they're also contraindicated for those taking aminoglycosides, since they both can cause ototoxicity.
Okay, let's move on to thiazides. Are these more commonly used?
Definitely. Thiazides, like hydrochlorothiazide, are widely used because they act on the distal convoluted tubule, where they inhibit the sodium chloride symporter.
So they act on the sodium chloride symporter, and they increase sodium and chloride excretion. And what are they used for?
They're perfect for mild hypertension, managing edema in heart failure, preventing kidney stones by reducing calcium excretion, and treating nephrogenic diabetes insipidus.
Do they come with any side effects? I remember there was a mnemonic for it called hypergluc.
Yes, the letters GLUC stand for hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. It also causes hypokalemia and hyponatremia, so keep in mind that potassium also gets excreted with the sodium.
Okay, last but not least, potassium-sparing diuretics. What should we know about them?
These drugs prevent potassium loss. As you can tell from the name, we have two groups. The first group is made of the aldosterone receptor blockers, which are spironolactone and eplerenone. The second group is made of the epithelial sodium channel inhibitors in the collecting duct, and those are amiloride and triamterene.
They can raise potassium levels, so that's great to prevent hypokalemia when they're used in combination with other diuretics. Where else would we use them?
They can be used to manage edema or hypertension, and because they block aldosterone receptors, they're also used to treat hyperaldosteronism.
Okay, that makes sense. And what about their side effects?
Potassium-sparing diuretics can lead to hyperkalemia if they spare a little too much potassium, especially if they're combined with potassium-elevating agents like ACE inhibitors. On top of that, spironolactone specifically can cause gynecomastia in men and menstrual irregularities in women, and this is due to its ability to block effects of androgens by binding androgen receptors.
Alright, so hyperkalemia, gynecomastia, and menstrual irregularities. And who exactly should avoid this drug?
Patients with renal failure or hyperkalemia should steer clear for sure.
Alright, let's take a moment to recap everything we've covered about diuretics. Shahd, let's go through each class one by one.
Okay, here's a breakdown. First, carbonic anhydrase inhibitors. They work in the proximal tubule, reducing bicarbonate reabsorption to promote sodium and water loss. They're used for glaucoma, altitude sickness, and some metabolic issues, but can cause metabolic acidosis and low potassium. Second, osmotic diuretics. Think of these as water magnets. They increase osmotic pressure in the proximal tubule and descending loop, pulling water out. Great for lowering brain pressure, eye pressure, or preventing kidney injury. Watch out for fluid overload and electrolyte imbalances. Third, loop diuretics, working in the loop of Henle to block the sodium-potassium 2-chloride transporter. They're used for heart failure, pulmonary edema, and high calcium, but they can cause low potassium, hearing issues, and dehydration. Now fourth, thiazide diuretics. These target the distal tubule, blocking sodium reabsorption. They're popular for hypertension and mild swelling. Side effects? Low potassium but high calcium, blood sugar, and uric acid. And finally, potassium-sparing diuretics. These protect your potassium. They either block sodium channels, which is the case in amiloride and triamterene, or stop aldosterone, as in spironolactone and eplerenone. They're great for preventing low potassium or treating hyperaldosteronism. Beware, they can lead to hyperkalemia, and spironolactone can also cause hormonal side effects.
Thank you, Shahd. That was a thorough recap. So you should keep in mind that while diuretics are incredibly useful, their potential complications, like electrolyte imbalances, need to be carefully monitored to ensure patient safety.
Exactly. Diuretics are powerful tools in medicine, but they're not one-size-fits-all. Understanding their mechanisms, indications, and risks is key to using them effectively.
Okay, now it's time for some practice questions. Let's start with carbonic anhydrase inhibitors. A patient is started on acetazolamide for metabolic alkalosis. What unique change does this drug induce in urine pH, and how does it help with this condition?
Acetazolamide increases urine pH by inhibiting bicarbonate reabsorption, which helps correct metabolic alkalosis by reducing systemic bicarbonate levels.
Okay, that makes sense. Now for the next question on osmotic diuretics. Mannitol is contraindicated in patients with heart failure. Why might osmotic diuretics worsen their condition?
Osmotic diuretics increase extracellular fluid volume before diuresis begins, potentially worsening fluid overload and causing pulmonary edema in heart failure patients.
So fluid overload. Got it. Now for loop diuretics. A patient on a loop diuretic develops muscle weakness and arrhythmias. Which electrolyte imbalance is the most likely cause?
Hypokalemia is the most likely cause, as loop diuretics increase potassium excretion, leading to reduced potassium levels.
Okay, now for thiazides. Why might thiazide diuretics be beneficial in preventing calcium-based kidney stones?
Thiazide diuretics enhance calcium reabsorption in the distal convoluted tubule, reducing urinary calcium excretion and the risk of stone formation.
Alright, now for our final question on potassium-sparing diuretics. A patient on spironolactone develops breast tenderness. What is the underlying mechanism behind this side effect?
Spironolactone blocks androgen receptors and has anti-androgenic effects, which can lead to gynecomastia and breast tenderness in men.
And that's it for today's episode on diuretics. Thank you for joining us, Shahd, and thank you to everyone for listening. We hope this helped simplify a tricky topic. Don't forget to follow and leave a review so you don't miss out on future episodes. Catch you next time on PodBites.